like to thank Mukesh for having me on this course on doses. I also start with acquired blepharocosis. Actually, in fact, in most sessions or in most instruction courses or sessions on doses, acquired blepharocosis or acquired doses comes actually towards the end. So I have the interesting task of starting with acquired, and that makes my job a little easier because the audience is a little more fresh as we start this session. So I'd like to welcome my teacher, Professor Vitharia, who has taught many of us, in fact all the speakers on this course, and his very favorite expression to all of us that the eyelids are like the jewels in the jewel box, and eyes are like the jewels in the gel box, and if the box is kept open or not locked, the eyes will be lost. So we start with this very favorite expression of Professor Vitharia with regard to the eyelids and the protective function. Now, not only from the point of view of preserving sight, but also from the point of view of mechanical and chemical protection, but also from the point of view of aesthesis and appearance. Now, this is a slide that shows a very famous Kathakali artist displaying virtually all the expressions known to man by essentially working on his muscles around the eye. So basically the eyelids, the brows and the periocular tissues are most essential for human expression and communication. So there is a twofold, very functional aspect of ptosis surgery and also a very important aspect of human expression. Now, how is acquired ptosis different from congenital ptosis? Of course, this can have onset at any age, including children. So we will come across some conditions where children have acquired ptosis. We often tend to think of it as congenital ptosis if it's a child. Very variable etiology. So we'll walk through some of the common conditions and not so common conditions. And obviously the management is based on the underlying cause. So there is no straight hand-me-down which you can take, look at the chart or exercise so much or resect so much. And obviously from this point of variable etiology flows the unpredictability of outcomes. So the unpredictability, it's actually much tougher to take care of a patient with acquired ptosis than it is to take care of a patient with straightforward congenital ptosis. Now, this famous probability of etiological classification of ptosis, I'm not going to go into that. Now, what looks strikingly as ptosis may not be ptosis at all. For example, in this patient with thyroid eye disease, it was this eye which was thought to be at fault by the patient's family, but as we know, there is upper lid retraction when the patient has thyroid eye disease. So once the patient comes to you with ptosis, do question whether there is ptosis at all or is there upper lid retraction on the other side. Similarly, this is a patient with bilateral ptosis in the neurology ICU, and obviously this is not something that you need to manage. The dressing on the head stays at all, that this patient has a hair injury and bilateral nerve palsy. Similarly, there is a patient with ptosis, and then obviously one will be very careful doing anything with this patient at this stage, wherein the eye is down and and you have a third nerve palsy. Similarly, this is a patient with another etiology. There's recurrent episodes of bleeding, and that suggests a condition like lymphangioma, or a very straightforward one like a chalazion. So it could be very or a post-traumatic patient that had a serious traumatic accident and then you have ptosis. But obviously this is going to be very differently managed from any other condition. When you look at an acquired ptosis, always try to look at a cause for it. In this case, even a cursory, a very cursory examination shows a draining sinus, and a CT scan coronal view shows a bony defecture and tubercular osteomyelitis. So in many cases, if you really look carefully, you will find a cause which you can address. Now, what are the important things, what are the important aspects to look at in a patient with acquired ptosis? One is the onset, whether it is acute, if it has been slow, progressive over the years, how long has it been, how long has it progressed. Any history of trauma is very important. Even some of the patients may have trivial trauma, but it could lead to ptosis. And in trauma, you could also include the trauma of using contact lenses, for example, not today, but earlier the hard contact lenses and the rigid gas permeable lenses used to cause microtrauma and also common cause for arthrosis. Variability, of course, is very, very important to look at. Diurnal variation, fatigability, diplopia is a very, very important thing, because obviously if you are going to actually treat a patient with acquired ptosis with myasthenia, you need to really know it is myasthenia before you treat it. We'll come to that in a short while. I find that this is absolutely an absolute must. I usually do not touch a patient with acquired ptosis if they are not able to show me some photographs prior to the onset of ptosis, because that's really, really, really important. Now look at this young patient who came to me in this condition with bilateral ptosis, and he had repeated episodes of sweating suggestive of blepharokinesis. And this was his old picture. Similarly, this is a child with acquired ptosis, but if you look at the child's picture when he was much younger, very, very massive capital hemangioma, which led to an ambulatory and ptosis. When we look at the ptosis examination, I'm sure it's going to be get covered, and also it's pretty much basic stuff. One must pay particular attention to the decreased height, because we know that most of the patients with so-called senile ptosis, many people don't really agree to being diagnosed to have senile ptosis, but acquired ptosis or pituitary ptosis of older age, the lip crease goes up and it becomes less prominent. So if you see an asymmetric lip crease, unilateral ptosis, the lip crease is higher and fainter, then you know that it is possibly a poneurotic ptosis. Thinning of the lip above the tarsal plate, in some of the patients who are very fair, you could actually see the cornea shining through, because the levator has the highness and there is actually less tissue between you and the cornea, so the cornea can be seen shining through. Fatigability is a very, very important test that we look at in accordance with the sign as well. Now, some of those conditions we just go over. It's more of it's a patient with what looks like ptosis, but if you really look at the history of the medical intern who met with the bad bone traffic accident and had massive fractures here, and all I had to essentially do to correct the ptosis was to do an orbital implant for correction of the inophthalmic kind of implant. Now, as far as investigations are concerned, you must perform certain investigations which are appropriate, including, in my opinion, an ultrasound examination or a CT scan of the orbit wherever you're not able to actually clearly find a dehiscence of the aponeurosis. Like this gentleman who had acquired ptosis and came to me for ptosis surgery, referred to me for ptosis surgery, but the ultrasound examination showed thickening of the superior rectus LPS complex. A biopsy was performed and showed a lymphoma. So this patient only needed treatment for the orbital lymphoma and not ptosis surgery. Similarly, this is a very, very interesting, is it in the back? Or can it slightly shut down? Now, this is a lady, actually very senior bureaucrat from North Indian state, who came to me in Chennai with history of bilateral ptosis, referred for ptosis. And when we look at her and we do a little test, her ptosis improves. What is that test? Basically, if you go back to her history, she was a middle-aged lady, she was diagnosed with thyroid eye disease. At that time, I used to run the thyroid eye clinic at Shankar Nagaraj. And she was referred to thyroid abnormality and also for possible correction of ptosis. I don't know how the two really were diagnosed together. She had minimal ptosis. Her ice pack test was positive. She developed difficulty breathing soon thereafter and actually needed an urgent referral and ventilatory support for 2 weeks. And she left the hospital very hale and hearty. So over the course of a follow-up at a major multi-specialty tertiary hospital, nobody had actually diagnosed her myasthenia. So there is a strong association between myasthenia and thyroid orbitopathy. We'll come to that. That is yet another test. Similarly, in this patient, referred to me for ptosis surgery from Mumbai, these two photographs are taken about 2 or 3 minutes apart. So in any patient with acquired ptosis, the ice pack test is a very, very simple test and must be performed and documented. It's surprising the number of myasthenia that you're going to pick up in your clinical practice and obviously avoid surgery, which can be disastrous in these patients. So in the workup of acquired ptosis, an ice pack test, which has got a very high sensitivity, very easy to do in any OPD setup, really gives us a lot of information and diagnosis myasthenia gravis very well. Now, coming to management, what are the principles? Of course, find cause. So this is not something that will exist in congenital doses, wherein we are much more confident of actually doing the surgical management. But in this case, find the cause, I think you should take up most of the effort, because once you find the cause, I think the treatment becomes a little more straightforward. I think rule out myasthenia is a take-home message for young ophthalmologists in practice. Do the eyes pack test. It's not a test which is painful, which is difficult, and it's a wonderful test. When you get a patient who's got myasthenia and you pick it up, I think it's a wonderful feeling. As far as surgical correction is concerned, you need to explore. Most of the patients would have some kind of an aponeurotic issue. Some of them could be repaired, advanced, but a large number of them would finally need levator resection. I'll come to a few pictures as we go. And some others can have, of course, suspension and other things, sometimes suspension. Now, this is a patient again, to emphasize a patient with thyroid eye disease. You can see the bulgy eyeballs with ptosis. So, always beware the patient with proptosis and ptosis. If you're sitting in a situation where myasthenia is very likely diagnosis, and this is the patient after medical therapy. I need to take a little more time. Okay? Now, this is the intraoperative picture showing dehiscence. Now, some of the patients who have acquired ptosis also have issues related to periocular aging. So, the patient with browpexy and blepharoplasty, the pre and post treatment fields. Another patient with internal browpexy. And some of the patients who have undergone ptosis correction. Some of the results are unpredictable, as we mentioned. This is a patient with the blepharochalasis, one eye operated, that eye is doing well, but later there was ptosis and had to be operated. Some of the patients, very rare, they have such severe condition that one may do facial autograft. We will not go into that. Bilateral brow lifts. The last and most important thing to remember is to beware patients like this, wherein a thumb surgeon had performed a ptosis surgery without looking at the Bell's phenomenon and ended up with this kind of a situation. This is the stage at which the patient came to us. In some patients, where surgery may be contraindicated for more than one reason, crutch glasses can be effective, but often patients find it uncomfortable to use it. This is a patient again to emphasize that with this kind of an appearance, bilateral ptosis, he looks as if he is uninterested, sleepy, and unintelligent, but after surgery, if you look carefully, things seem to have improved. I think there's no time for a video in case at the end you have time. I'll be happy to show that. Thank you very much.